Well, good morning, folks. I am here with the first episode of the NCA on the Road. I am at the Oregon coast with my family. We came down this weekend for a little time with my mother-in-law and father-in-law down at Seaside, Oregon. And we've had a lovely day out on the beach yesterday playing. Some of you may have seen some of the posts that I put up yesterday of being out with Five Dog Ruffed Girl. And today, predictably, we have rain at the Oregon coast. I think every time I have ever come down here, it has rained. Just so that some of you guys that are over here on Facebook Live can get a sense of what the heck we're doing. Over here, I've got a Zoom meeting, and this is how we roll with the NeuroCentric Approach Online Academy. Some of you may be members on that. We've got one member in the Zoom meeting right now, but what we do with these meetings periodically, right now we're just trying to get people familiar with it, and that's why we're doing as much as we are on Facebook Live. But as we continue and grow the community here a bit larger, than what we will start to do is periodically we'll have special guests on our Zoom meetings, and we will curate that material that we record off of the Zoom meeting and make continuing education courses out of that as well. Those of you that are new to what we're doing over there at NCA with the courses there, NeuroCentric Approach is our Dr. Justin Dean and I's attempt to try to put together a thoughtful, integrated assessment and intervention process for all of the variety of named systems that many of us in geek world and physical medicine are involved in. Mark Heller just asked a question. Can you comment? Yes, please. Come on, Mark. Let me see. It doesn't look like you're on yet. So we'll all just enjoy a little coffee for a moment while everybody gets going. Then I'm going to discuss a couple of cases that I've been playing with this week, and we will see what we learn. Okay, Stephen, is that Capo? Which Stephen is this on here this morning on the Zoom? Hello, Cameron Ross. Nice to see you on here. Okay. Let me see. Okay, we'll wait for a few more come on here. I am wondering, is there anybody on here on Facebook Live that got the email to the members that I sent out for the Zoom meeting? Did you try the Zoom link? Wondering if I flubbed something there. I would typically expect us to have quite a few more people on here. Okay. Somebody's sending a message here. Let's see what we got. Okay. There's Mark.
Well, I tried all kinds of different ways into the Zoom meeting and finally got there, but had trouble getting on the Zoom meeting. So
Okay, good.
I'm going to close the Facebook, because I don't know how to really use that one.
Yeah, I suspect we're going to have that periodically with this. But thanks for your perseverance and getting on here. So, folks, let's see what would be the easiest way for me to put a link. I think I have my Facebook, or excuse me, my Zoom link saved on here on Facebook. Let me see if I've got it. Man, it is really pouring down rain out here, man. Is it raining in Ashland, Mark? Okay, there we go.
AQI is over 150 in Ashland, so we're looking forward to that rain getting here, which it's supposed to.
Yeah, I know what you mean. This would be that season-ending forest fire thing that we're all kind of looking for. All right, I think for you guys on Facebook Live, I have added a link on there for my my Zoom link. If you guys over here on Facebook Live want to join over here, you can do that. It might be a little easier on all of us if we eventually coalesce around one platform or the other instead of keeping one foot on the dock and one foot in the boat here. Okie doke. So we got a quorum here, and Mark and I have been pinging each other this morning a little bit offline about this topic of hip stuff that I proposed for a topic of conversation to get started with around a couple of cases that I had this week that have been ongoing for a while. And basically, I think I overlooked some things, and I wanted to chat about that and own up to it and try to get better. I'm going to break those out initially, and then we can use them as talking points, and you guys can jump in here with comments as you like. If you're on the Zoom meeting here, feel free to use the chat function and drop a question in there, and then I can kind of come in and answer those periodically. Over here on Facebook Live, you can do it there as well, and I can see if I can pick up on those. Okay, Maria, welcome in. Okay, so two hip cases that I'd like to discuss this week. Both of them, as work for me tends, sort of center around powerlifting, since I have one of my offices is in Kabuki Strength Lab. So I've got two competitors, worlds. One of the world meets is coming up in the UK in a few weeks. So we've got some athletes traveling over there. And one of those is someone that I have seen in the past, a female lifter with hip pain at the bottom of a squat primarily. So for those of you that are aware of that movement in powerlifting, it's a back squat where the weight is on your back and you squat down below thighs parallel and then come back up. And she was experiencing pretty significant pain about a year ago when she was doing meet prep for qualifying for Worlds, which she did. But she was feeling pain at that point between the eccentric and concentric portion of the lift. And there was no pain at any other time. I will admit to my bias when I see an athlete with, especially in that sport, with pain that wraps around in the groin and goes down the medial aspect of the thigh. I'm thinking operator nerve. And my bias got the best of me on that, and I worked it. And kind of like what we saw last week when we were talking about some of Brandon Fromm's questions about his patient with iliohypogastric nerve involvement. One of the things that characterized our treatment previously with this athlete was that I would work on the neurology that I felt and had determined was sensitized. And when I did, her symptoms would get better. But the benefit was transient and her symptoms would keep coming back. So I would like to introduce that as something that all of us playing this NCA game should keep our eyes on. When you are treating a patient and you're getting good results with your DTM or your TNM or whatever we're leveraging against that, that interface between the nerve and the other tissues, if your benefit is only temporary, then likely your problem is upstream and you're just treating symptomatically. So in this particular athlete, we were able, I think it was 9 months ago, to get her through her qualifying competition. She set records, national records, which qualified her to go to Worlds. She set PRs for herself. And she came in just last week reporting that her pain, which had been completely gone, came back after she recently had a bout with COVID. So she got knocked down with COVID again. I think this was her third round. And for her, like many of you guys that are seeing COVID patients right now, the symptoms seem to be primarily, what I've seen so far anyway, just fatigue. Not a whole lot of nasal stuff, not a whole lot of GI distress, but a whole lot of fatigue. And she got laid down hard for about a week and didn't train, barely got off the couch. When she did get off the couch and went back to the gym, she had worse pain than before in her hip. So she came in, and as part of my screening, this time she was suggesting that the pain now, rather than being very localized in the medial aspect of the proximal thigh, her pain was now radiating all the way down to the distal part of the medial aspect of the thigh, all the way down to the knee. And, you know, as I'm looking at that in her intake, I'm thinking, okay, well, neurology services that particular area. And, you know, my bias got the best of me again. And what am I thinking? Saphenous nerve. Maybe we got some saphenous involvement, because right there in the mid thigh, we have some saphenous overlap with the obturator. So I'm going to share screen now and pull up some graphics so we can all review a wee bit. And let's start with this one here, which is our dermatome reminder The saphenous is the purple down here in F, and the D here is the obturator nerve. And going up here a little more proximally is the genitofemoral nerve. So what I started to think, and my clinical reasoning before I even saw the patient was, okay, if we've got overlap right here, maybe I missed something, or did I miss it and it was saphenous all along? Or is it something proximal and upstream? So I did something that I've talked about in other classes. Some of you have taken the clinical companion to Fix Your Own Back. I did something that I've talked about that I learned from a physiatrist a number of years ago by the name of Jay Shah. He's at National Institutes of Health. He told me about some physiatry researchers that described something called spinal segmental sensitization. And Mark, you're going to love this one. This was a bunch of physiatrists basically looking at the same thing that osteopaths and chiropractors have been looking at for a number of years. And they defined what they referred to as spinal segmental sensitization, which for all the world sounds a hell of a lot like Irvin Core's facilitated segment hypothesis that many of us learned in school. But the way that they would work their patients up is they would take something that was a little bit sharp. You could use the little device for sharp and dull discrimination that some of you have on your reflex hammers. But you can also go low tech and just use a paper clip and bend out one end to the pointy end. And you just draw it down across the various dermatomes, looking for a patient report of hypersensitivity, hyperalgesia, or even allodynia sometimes. You can also sometimes, when you do that, especially on the flanks, you'll get a little twitch sign that will pop up. But I was looking for a patient report of more or less sensation as I drew the paperclip around her thigh, all the way 360 degrees from proximal to distal. And I got her permission. And used an ink pen and drew a mark to literally dermatomally map out the area that was showing up. And as I crossed over those particular areas, I started to see what looked like this. I started to see something that pitched me back upstream. Now, initially, when I was working with this athlete, I thought she probably had an upper disc issue going on, but I always try to check my bias on that because the numbers are not good on it. Most of you understand that when it comes to disc herniations in the lumbar spine, literally 95% occur at the lower two lumbar levels. So I'm on kind of thin ice, statistically speaking, if I'm looking at an upper lumbar. But if you don't look, you won't see it. So in this particular case, as I wrapped around the thigh, she was showing me on the anterior thigh sensitivity that was starting midway right on the anterior thigh. And it went all the way around to the posterior quarter of the medial aspect of the thigh as well. And I'm like, ruh-roh, looks to me like we've got entire femoral nerve involvement upstream. So I tracked that out. And lo and behold, what did we find? Well, I asked her, because previously we had done the motor testing, I asked her if she had had any weakness, and she did not have any reported weakness. And we had previously done the sit to stand on single leg for 5 reps, and there was no apparent weakness on that to get me excitable. So this time I went back and asked her if she had done any Copenhagen work to test the motor to that medial compartment. And she said, I can't do that. It's too painful. So we went in and I had her do that. And indeed, she had like an 8 out of 10 pain when she tried to do a Copenhagen on that side. So for some of you that are listening to that, don't know what a Copenhagen is, it is a static. I know that's probably you there, Mark. This was that's good. It's good to check that one out. There was a paper done several years ago, several papers actually, by a research group of physical therapists that were working with professional footballers in the UK. And they came up, I think it was the UK, but it was training the adductors. So imagine side lying with a bench, and side lying on the floor with a bench, and you put your superior leg up on the bench, and then you plank yourself using the adductors into a static plank, so that you bring your entire body up and it's being held there by the effort of the adductors, the hip adductors. And then you pull the downside leg up to bring those legs together. And you can use that. We use that in some of our athletes as a way of marking whether they are fully recovered from disc herniation when our competitive power lifters are getting back under bar. But in her, she couldn't do that. So we theorizing that there might be a disc which had been underappreciated previously and possibly some nerve root involvement. We used the NCA approach or the NCA perspective, and we went back upstream to the neurology at the spinal cord nerve root IVF place. And we leveraged a couple of interventions towards that interface. We did prone press ups, and I did a overpressure at L3 area while she did those. And she did 2 sets of 15. And then I repeated the sensory testing with the paper clip around the thigh, and the area, the distribution of the sensation that had been hyperalgesic had shrunk by 50%. So that was kind of cool. That's the first time I've seen that. And then we went back to the Copenhagen, and she did an attempt on the Copenhagen plank. And she had now had the ability to actually get up into that position, but she can only hold it about 5 seconds. So then we leveraged another input at the nerve root IVF and did static openers. And also with the static openers, she did some neuromobilizations on that top leg. She went back onto the table. I did the sensory testing again, and it had shrunk down yet again. The dermatomal sensitivity area had shrunk down yet again. Now she went back to the Copenhagen, and she could perform that for about 15 seconds now. Now, if we're going to be intellectually honest, it's entirely possible that we've got all kinds of misreporting that's going on there. It could be that she's just getting stronger and her body's getting more aware of the process she's doing with the Copenhagen issue as she's doing that, and then she's just getting better. She's learning the motor behavior. But I thought that was worthwhile enough with the observed sensory and motor changes to bring that up to the group to discuss a bit further. She is actually moving away, so I won't have her as directly to be able to check and see how her symptomology is, but I'm quite optimistic that when she goes for her next training session, if she leverages those two inputs, that she's going to feel a lot less pain and probably feel stronger there, and will likely have another world record holder. Now, when Mark got in touch with me earlier, and Dean, Justin, welcome on. When Mark got in touch with me a little bit earlier, he had some thoughts about anterior hip pain and so-called functional hip impingement. And when Mark's got thoughts about something, I think it's important for all of us to listen. There's not many of us out there in the world that have been doing this thing longer than Mark Heller and thinking about it critically. So, Mark, what do you got on your mind, brother?
My observation about you, Philip, is that you always focus on the nerves as the source. And I respect that because it's like your unique thing. But when someone has anterior hip pain, I want to know, is that hip moving properly? And the typical pattern that I see, again, this is the work of Lucy White Ferguson, a chiropractor in Taos, New Mexico, with some tweaks by me. The person will have tenderness over the head of the femur. And you find the head of the femur by bisecting a line from the ASIS down to the pubes, bisect that line, go down about 1 centimeter and push in there. And if the hip is subluxed in an anterior direction, that will be both stiffer than it should be, and it will often it'll be tender, either exquisitely tender or somewhat tender. So that's one test. The other test I do, and I tend to do this supine in a 90-90 position. One could argue there's better positions to do it in, but I'm always assessing range of motion of internal rotation of the hip. And a lot of these people will have lost internal rotation. The interesting part is, especially on females, you really have to compare side to side and hope they have a unilateral problem, because for Mark Heller, if I get 15 degrees of internal rotation on this 73-year-old male stiff body, I'm happy as a clam. On some females, 20 means if they have 20 on one side, 40 on the other, that hip is stuck. And the third test is a manual muscle testing of the hip flexors, bringing the hip up to 30 or 40 degrees, sometimes with the knee bent, sometimes with the knee straight, and seeing is that the hip flexors get weak when the ligament in the front of the hip is being pressed on. Now, maybe it's a nerve thing it's being pressed on, but that's the 3 criteria for what I call a functional hip impingement. And those would be, it's 3 index tests, not 1. And then the first place I go with that, again, using the CAP protocol, if the person's not a motor moron, I will show them a variation. I call it side plank plus, and those in the DNS world call it low diagonal oblique sit. So I watched Craig Libenson teach low diagonal oblique sit many years ago, and then repurposed that as an exercise for the hip. People do it, hold it for 10 seconds. I probably have tweaked low diagonal oblique sit because I'm having the person not push into the floor, but push into a wall, a padded wall. And basically they're activating the side core and they're activating the glutes in a isometric or possibly eccentric manner, and it pushes the femur back into the socket. So the idea is that this is a subluxed, and I'm not big on chiropractors calling everything subluxation, but The hip is
Jerome
stuck.
Fryer's already calling you out over here.
The hip is stuck too far forward and stuck externally rotated. So what does a lay person do when their hip hurts? They go to yoga oriented hip opening exercises, which is totally contraindicated in this because that takes the femur further forward and further external, which is the opposite of the direction we want to do. So sometimes I get great results by just telling them, this is what you shouldn't do anymore. So, and that's a piece I'm always looking for in any anterior groin pain. I start there.
I like it. I think, and thanks for calling me out on my biases, because I certainly deserve it. We all do. Who was it? Feynman said, first thing you need to realize is or in science, the first thing you need to do is to try not to get fooled. And the second thing you need to realize is the easiest person to fool is yourself. Yeah, I am certainly biased, and intentionally too, in this particular forum, since we are here ostensibly to describe this NeuroCentric approach, that we're going to put neurology forward. For what it's worth, the sports hernia, Mark and I have just been back and forth this morning talking about various ways of presenting material on the hip, and I'm trying to figure out how to put the coursework together for it. And I'm leaning towards shorter bite-sized pieces of 30 to 60 minutes long. Do the medial inside of the hip, maybe pelvic floor. I've got the sports hernia on the editing board right now. Then one on anterior hip, then one on lateral hip, then one on deep gluteal pain syndrome, and so forth. But for the sports hernia right now, every one of those courses has a current evidence presentation of an orthopedic of an orthopedic exam. Was just having a nice conversation with Rob Tenhove up in Calgary the other day, and part of what they're looking for in order to get the coursework on the NCA Online Academy possibly certified in province of Calgary, which is a little challenging, as my Canadian folks on here probably know. But we got to have best evidence for standard orthopedics and stuff is demonstrated as well. So we do. And all of the things that you just mentioned as well, Mark, are in that. In a supine patient, I'm going to do anvil test. In a standing patient, I'm going to have them do a heel drop, 2-leg and single leg. I'm going to do hip scouring. I'm going to do a Fader, F-A-D-I-R test, and I'm going to do a Faber, F-A-B-E-R test, and then a supine internal rotation test with a hip at 90 degrees. All of those looking to rule out arthralgia, frank hip joint issues that are pushing that. So I'm with you. That is on my radar when I do it. But before I go there, I check the other issues with the neurology to make sure I'm not overlooking a possible driver for that issue. I too see what I believe to be an anteriority there of the femur in the acetabulum, and I will park that. Further comment on that for the moment and drop into the second case study that I wanted to talk about that I think will help to illustrate exactly that. And this will make you smile, Mark, because I did exactly what you're talking about, and I overlooked the arthralgia and prioritized the nerve, and I got temporary benefit yet again. So this particular patient that I was seeing is quite a bit older, competitive power lifter. And he presented with very proximal medial hip pain, primarily with deadlifting. Was initiating the deadlift, but also with squatting. And the symptoms were only notable on the beginning of his workout session, primarily pulling. So he was doing his straight bar deadlift sessions. And when he would warm up with 135 on the bar, he would have really nasty pain, as high as 8 out of 10 pain, right up on the proximal adductors in his hip, only on one side. And again, my bias in that area is I want to rule out the obturator nerve. And I went in there and with tension testing and with palpation, thought I found a hot obturator nerve, and I got all excited about how cool I was. And then I leveraged a bunch of our cool NCA things on that obturator nerve, and he got remarkably better. And then the second session, he came in and reported that, oh, and here's something important. When he would start his workout at warming up with 135, he would start out with that 8 out of 10, and he'd do a set of 10, and he'd do another set of 10. And by the time he got done with that, the pain in that area had dropped to something that was very manageable, as 1 or a 2 or something like that. And then he'd go on and he'd do his deadlifting session, and it would not get worse with his deadlifting session. So now what does that pain pattern sound like? That sounds for all the world like a tendinopathy, right? That is the tendinopathy screaming at you. It is worse at rest. It gets worse when you first start using it. And then when you use it a bit, it gets much better until you overuse it, and so forth and so forth. But what do we know from Karen Silbernagel's work, even going back to Alfredson's work on tendinopathies and what we do with those? How would you address that? We'd use either isometrics or eccentrics, or Silbernagel kind of brought us up to speed and said it's not about the eccentric versus concentric. It's about slow, heavy loading of the tendon. Now, for any of you familiar with powerlifting, what does a powerlifting session look like for this particular athlete? It looks like a lot of very slow, very heavy movements. And indeed, he would feel better, but it doesn't get better over time. So either one, that loading was too much, and we've got to pull him back, which is not what you want to do to an athlete who is prepping for a competition in the next several weeks. So I opted then to treat what I saw as the involved obturator nerve. He came back in after the first session, reported that his pulling session that particular day was, his warm-ups were 80% improved. I was like, rah, rah. So he came back a week later before his next pulling session. And the goal then was, what can we do to improve your warm-ups on that session so that you don't need me or anybody else working on you? Let's develop a better pre-event, pre-pulling session warm-up. So what I had done in that particular area that had helped him was mostly using the Stecco approach, doing cross fiber friction at what would be media pelvis for them, and also media genu further downstream. And lo and behold, we took him out onto the gym floor and took some of those very heavy weighted rollers that Kabuki's got laying around. This particular variant, it's called the Geisha. And it was, I think we had 135 pounds on that. And we got Rudy into a position to roll the inside of his thigh with that 135-pound bar. And he did that, and to loosen that area up to work on the putative interface issue. And then I coached him through some very wide horse stance movements where he would take a kettlebell and alternately push it and pull it to keep him in a safe zone so that he's actively working while he's got that area at length. And he came back and reported that he was much better. So we were gonzo that we were on the right thing. Now, what I didn't say is the initial exam that I did on Rudy, the hip screen, he was positive on several of those tests. His internal rotation reproduced the pain at CC and supine when I challenged that joint into internal rotation. We had pain there, and his FADIR, FADIR test was positive for a possible impingement situation going on there. This guy's 75 now. He's been powerlifting ongoing for 10 years. Been at the top of his game for 10 years. And here's where we go into the other part of what Mark was talking about. In the DNS world, which is where Craig got the information that you were citing there, Mark, about the low oblique sit stuff. In the DNS world, if the spine is not being held in a stable configuration when you ask the psoas to do work, then the psoas will, according to DNS principles, need to first pull slop, if you will, out of the spine to create a stable origin to have an effect on the femur. And there we can go back to one of Stu McGill's papers where he was asking, is the psoas a prime mover or is it a stabilizer of the spine? And from a DNS perspective, it can be both. It should be both. But the spine should first, in order for it to be a good phasic muscle, a functional phasic muscle, the spine should first be held in a stable position so that the psoas can take action more effectively on the hip. Now, in DNS world, if the psoas is getting a read that the spine is not first stable, as it pulls slop out of the spine, and Jerome can comment on this from probably some of his research, then the spine will be pulled into rather interesting positions. You'll be pulled into an exaggerated lordosis and a little bit of lateral flexion if it's a unilateral pull. And owing to the attachment on the femur will be pulled anterior in the acetabulum. And the combination of those things will give you an anterior pelvic tilt and an anteriority in the femur and the acetabulum, which will cause an impingement process on the anterior part of that hip. And I think that's probably what you're seeing there, Mark, that you're describing. So what's one of the ways that DNS would suggest that we assess the intra-abdominal pressurization in that particular individual? We might check IAP by having them in supine do a 2-leg raise 6 inches off of the ground and look for a rectus diastasis. This particular individual that's having this I've been letting this go without comment, watching him around the gym for months, but he's got a progressively worsening rectus diastasis. And I haven't been saying anything about it because I didn't feel like my skinny behind had any right to tell the world record holder of 10 years that he needs to change his form in any particular way. It seemed to be working for him pretty well. But now I decided, well, let's go see what we can do. So I took him out onto the floor and we tried a wall bug, which, Mark, you might remember that from some of Craig's classes. And I put him up on a foam roll, put his palms on the wall, had him depress the ribs and try to get the TL junction pinned into the foam roll. And then with knees at 90 degrees, alternately flex each leg and touch the heel to the floor. He couldn't do it. He couldn't do it at all. He was coming off of the roll, so we pulled the roll out, put him on the floor. He couldn't keep his legs up above his belt line with his hands on the wall. So we peeled him back to log rolling, and I had him to do log rolling, what Craig would call your best, the what you're most proficient at, and on the edge of your ability. And had him to do some log rolling. And then his index test that we were using, which was him pulling the leg up in a position to cause a snapping hip, which was what he was showing me. He couldn't make that happen, and he couldn't make the hip pain happen anymore. And that was just from the functional intervention. I hadn't done any manual therapy, no treatment on the obturator nerve. So it made me think we're looking at a couple of things going on structurally. I'm probably looking at an obturator nerve that is a bit unhappy. And I'm also looking at a hip that's a bit unhappy. And I'm looking at the reason for that. My narrative right now is that the stabilization strategy that he's demonstrating is off base. That's resulting in the anteriority in the hip joint and causing that. And the combination of all of that and the lack of stabilization on the front of the abdominal wall is what's probably giving us, and the hypertonicity in the psoas is probably giving us the interface dysfunction that I'm observing at the obturator nerve. So hindsight's 2020, right? And all of it is about creating a compelling narrative at the end of the day. That makes sense to me, but I'd be interested to hear what anybody else has got to think about. Justin, you have any input there? Jerome, you have any input there, brother? Crickets.
Hey, Phil, it's Maria.
Hey, Maria, how are you?
I'm great. I'm really good. No input on the second case. It's great to go back to basics, and to not overlook like the really, I don't know, the foundational stuff that we started in our rehab. Yeah. I have a question really about the first case. What's your theory? I mean, it's so unusual to have an upper lumbar disc, and especially in a young, super fit athlete. What's your theory of why that might have occurred for her?
I would first take your statement. Very interesting to have an upper lumbar disc in a fit young person. And to that, I would reply with Michael Adams' paper on this. He's the researcher that I interviewed a number of years ago. He's a biomechanist at University of Bristol in the UK, and he co-wrote the book Biomechanics of the Spine. Nicholas Bogduck was third author, I think, on that. And so one of Adam's papers, he showed us that there are two phenotypes in disc herniation in terms of older versus younger. And upper lumbar, in younger athletes, they are more likely to have a upper lumbar disc herniation. The other thing that I would toss out there for towards your question is, and asking why I might be seeing this. This is an interesting sport. powerlifting. So they are taking a whole lot of load in that particular area.
Yeah.
And it all has to do typically for them, if they're having that pain at the bottom and it is disc related, it has to do at what point in their descent they lose the ability to keep a somewhat neutral spine, and they start to lapse into that butt wink phenomena that we see at the bottom. And two young athletes that were exactly that situation this past week. Both of them having pain in the hole on squats. Both of them have been coached previously to initiate their squat with a strong anterior pelvic tilt and strong extensor tone, and no recruitment of the abdominal muscles. And both of them, when we looked at them, on film and in side position or lateral position, both of them exhibited a wink right there at the bottom. And one of them was earlier in that, and he was showing that hypermobility at an upper lumbar segment as well, around L3. And remember, McGill also taught us about assessing for that in a quadruped position, and the clinician will look from the side and have the patient in quadruped to rock back, taking their butt towards their heels. And they rock back slowly until you see that the spine loses a neutral position, and you mark that particular point that they go initially into, they start flexion in the lumbar spine. And that usually is your hinge point that they're having issues with. So that's what I think is a decent answer to your question, Maria. How'd I do?
I think you did great. And I think that was really the point of my question. Like, are we really looking at mechanics? Like in these, even though they're advanced athletes, are you just looking at a simple squat movement pattern to just see if you see anything like in the adductors with the butt wink? Are you really looking at ankle mobility? Are you looking at mid-thoracic mobility? Are you even looking at eye patterns? Like all of those things could greatly affect squat compensation that could lead to that kind of disc.
Agreed completely. And a lot of, it sounds like a lot of what you're nudging us towards there is to consider the other schools of thought on this, like, what Gray and Greg did with FMS and SFMA. And indeed, what you'll see as you go through the courses there on the site, what we do in our clinic, what I teach my students is an upper and a lower quarter basic orthopedic and neurological examination. And that high-level organization, the high-level organization of that incorporates some of those elements of the top tier investigations of FMS and or SFMA. So I will have that patient squat to depth, and I want them to stay there as well. And I want to look at them from the front. I want to look at them from the side. I want to see how their foot is bearing weight. Are they collapsing in and showing me valgosity at the ankle? Are they showing me strong anteriority in the footbed, and they're not able to keep their heels down? What does that show me about from the side? Whether they have that anterior pelvic tilt and they're going into the butt wink and all of that fun stuff. So yeah, all of that is baked into this. And to my mind, the difference in what we're trying to do with NCA is we still mark that. We still check that box and we make a note of it. We keep it in mind. But all I'm really trying to do is to take the neurology and specifically the mechanical sensitivity of the neurology and put it forefront in the clinician's mind so that they don't let it escape their attention and instead go lapsing onto the well-worn path that we have of meat-based issues of looking for hypertonicity in a muscle, looking for fibrosis in tissues, looking for joint hypomobility, and just wading into that with a big chiropractic hammer to hammer down high spots and try to restore mobility in those areas without asking why is that happening there. Because over the years, as I've asked that why over and over and over again, I keep coming back to there's a neural driver in that pain syndrome that's going on that has not been thoroughly investigated yet. And when we do that, the hypertonicity often gets better and the joint position often gets better, especially when we put a DNS foundation underneath that. And here's a dirty secret right there. If we want to dispense with all this silly NCA-ness, we could all just go back and be DNS practitioners. I swear, I do think Carl Levitt was right. You know, Craig used to tell a story about being over in Prague and walking around the hospital with Carl Levitt. And this is in the early days of Pavel Kolaj getting, you know, describing what he thought he was seeing with DNS. And according to Craig's telling of the story, Carl says, I want to take you down here and show you this. And Kolaj was lecturing in a room. And Levitt says to Liebenson, this guy might have the answer we've all been looking for, but I don't know how in the hell he's going to teach it. And therein you get to a lot of the frustration that many of us over the years have had with DNS, that it is incredibly powerful, but it's hard to describe. It's hard to feel, ironically, because we're talking about holographic motor template that we're all supposedly carrying in our brain that is innately there. And yet we spend an inordinate amount of time talking about it with our patients, trying to tell them how to do it, which is against the literature that would suggest that internal cueing strategies are inferior to external cueing strategies. But Kolaj does not want to give up on the internal cueing strategies in working with patients. But what we don't have evidence on, that Jeff Kubos brought up adroitly a number of years ago, was we don't have any evidence about whether the combination of what DNS actually does at the end of the day, which is kinesthetic cueing combined with internal cueing. So remember your passive assistance of positions. You put the patient in one of those developmental postures. You see whether they can actually do the developmental movement. And if they can't, you passively help them by unloading somewhat so that they can get a little bit of a rolling start on the movement and see if they can do it better. But yeah, I mean, I saw this years ago when, you know, students from my clinic, after working with me, seeing patients with disc injuries, walked into DNS practices by that and worked in DNS practices. And they were being shown in those DNS practices ways to manage a lumbar disc herniation just by going through evaluation of intra-abdominal pressure and coaching developmental postures and getting that patient out of harm's way with that lumbar disc herniation. And you know what? It worked. But you know what else? It literally took them 2 to 3 times as long to get better than it did leveraging the integrated approach that I had taught that student, which also integrated DNS. So on that patient, those of you that have taken a clinical companion to FYOB course, we would leverage McKenzie, we would leverage static openers to take the threat off of that particular involved neurology. And then we would come up underneath them with that functional fix from a DNS perspective. And people get better faster with less treatment. So, what else we got out there? Jerome, you sent me a couple of papers this morning. They were cool. Are you within earshot over there? You want to talk about them? I could see if I can pull those up. I'm not on screen share right now, am I? Doesn't look like it. Okay, looks like you guys might be getting tired. All right. Justin, you have any input before you take off? So to give you guys a little bit of an idea of the way that we're going to work some of these in the future, Justin has set up a film studio setting at his place, and in advance, like some of these meetings, maybe the next one, I'm going to do a deep dive on one specific nerve. So we'll just pull one nerve out, we'll look at its origins, we'll look at what it does, we'll look at how it interacts with other tissues and how we address it. And then we'll use those likely as continuing education. I'll put a slide deck together for it. We'll try to come in under an hour on it. And then Justin will use a model and demonstrate the manual techniques of both assessment, manual, and exercise intervention from his place down in LA. And let's see, other things. My associate is now back from his vacation, so we will be filming on Monday to get the practical portion of the sports hernia course out. And that will likely be dropped on the site in the next week. The tendinopathy course, I've followed up with an email to one of the primary researchers that I'm really fascinated in, where our work kind of at NCA kind of dovetails with his. His name, for those of you that are geeky and interested, is Paul Ackerman. He's a Swedish researcher. So Ackerman is Ackermann. Paul Ackerman has been bird dogging the effect of neurology on tendinopathy since back in the first paper I'm aware of that he did there was like between 2006 and 2009. And from a historical standpoint, this was at the same time that Jill Cook was really coming on with her research on tendinopathy. And Cook gave us a lot of how the dominoes line up on a reactive tendon, that then you'd have a proliferative phase and a failed healing and a degeneration phase. And it was Ackerman's work, though, that again, Cook being, and Craig Purdom as well with Jill Cook, being very, very focused on the meat, if you will, is Ackerman was swinging us around to nerve. And his research shows us that the source of the nociception on a painful tendon is not due to vascularity and not due to something in the tendon itself. It is the ingrowth of nerve buds. And I've had a couple of conversations now by email as well with Jeff Bove and I'd like, I've talked to Paul Ackerman about coming on and doing a presentation for us here, but it's going to cost a fair bit for us to get him on there. I've got a little bit of a relationship with Dr. Bove, and we might be able to get him on here out of the goodness of his heart and to help create a little bit of a stir for the neurodynamics colloquium that Michael Shacklock has got going on down in Dallas at Parker. So Bove's going to be there. I think Antonio Stecco's coming into town for that, and Annie O'Connor from World of Hurt as well. It'd be a good show. You guys should keep that on your radar and go check it out if you like. All right. Anybody got anything?
Hey, Philip, can you unmute me? I can't figure out how to unmute my microphone, and my app's being kind of weird.
Okay. Asking you to.
Can you hear me?
Yes, sir.
Yes, sir. Okay, yeah, sorry. So you asked me about anything to add, and more just from like a structural organization of NCA as far as the thought process. And this was related to Mark's question when we were talking about the hip and how we seem to be very biased towards the nerve, which is, of course, is true. One of the things that the way I look at the way we structured this, the system and approach is kind of to separate into two different models in a way, the pain model and the overall functional performance model. The thing that we're trying to bring, and I think Philip, you'll agree, is with NCA is a roadmap to get people out of pain very quickly, but that does not negate biomechanics, orthopedics, and the structure of the hip and every other aspect of clinical care. It's just a very quick roadmap to get somebody out of pain, and then it likely will address some of these biomechanical issues that you'll see, like a anterior superior position hip. And it doesn't mean that necessarily you wouldn't do the other interventions to additionally address that. NCA, where it shines, is to reduce pain very quickly, and then you can move on to, let's say, a more functional roadmap.
Agree. Yeah, we've and Justin and I have gone back and forth about this over the years a few times of how to behave responsibly with that, because Mark, I think you probably saw this early on as well. I know you were really keen to the YAP DTM stuff that we were playing, but Justin and I saw at least once, maybe a few times, that we were able to do something that could take pain out of a motor program very quickly. But if you don't assess for the other meat-based biomechanical arthralgias and things of that sort, and the functional reasons for them to be there, and you just keep taking the pain away, you may be doing a disservice to that particular individual. And we might be essentially just applying some kind of manual aspirin that pushes the patient further into lesion and causes a worsening of an orthopedic condition that they had. So I think we need to be responsible in the way that we address with this. Is ability to be able to take the pain away by addressing some of that sensory neurology is a pretty cool thing. But like any kind of power, when you get it, you got to be aware of the responsibility that you've got and behave responsibly with it.
Yeah, I'll just, sorry.
Go with it.
All right. So, yeah, absolutely. So another way of thinking about this from a, hold on, I'm getting a phone call.
I'm not here.
Huh?
I'm not here.
Did something happen? We're good? Okay. Another way of thinking about this is like, let's look at this over a series of visits, right? Where does NCA fit into a new patient to start to finish with a patient? It's really most important in, let's say, like the first 3 sessions. And then that's usually what it takes for most, let's just say basic cases, hip pain, back pain, neck pain, knee pain, that kind of stuff, to reduce the pain by a significant margin. And then you could transition into other systems and approaches, and with the NCA lens still attached. So it's really the, how do we make a huge difference in what the person is paying us to do, which is get rid of their pain so they can do what they love to do as quickly as possible.
Yeah, I've got another lifter that is a perfect consideration of that. And those of you, if you have seen, if you haven't already, go look at the shoulder course that I put on the online academy. The shoulders are a perfect example of this. Commonly, and the hip as well, you know, your 2 big knots that Pavel Tsatsouline talks about. These inherently mobile joints often, from a biomechanical standpoint, might become a little less functional because a neural driver is causing the muscles in that area to act differently. So I had a lifter that was she was preparing for an odd type of meet that combined elements of Olympic lifting, or so-called weightlifting, and powerlifting. And she had previously competed in both. And she came in, you know, with really, really nasty pain in a catch position for clean and jerk, and a really nasty pain in a high bar back squat position. Her pain was right on the front side of the shoulder. And working through the neck, we were able to get her through that competition. And then she stopped seeing me. She didn't come back. And when she came back in, she had a full-on adhesive capsulitis. So we were able to make things better going through the neck, but then her lack of movement and lack of addressing the actual capsular issue, she wound up with an adhesive capsulitis. And here's one for you guys as well. I sent her out to a local pain interventionist to do capsular distension, which has the best evidence for that. But it doesn't, it's not terribly profitable in a pain interventionist practice. I sent her out. They took an MRI. The MRI showed a lot of degeneration of the rotator cuff tendons. And they prescribed PRP for those tendons, followed by extracorporeal shockwave therapy. Now, both of which have about a 50%, success rating in the literature. Both of them cost a lot more too. So they wanted her to book in for extracorporeal shockwave therapy at $300 a session for an hour, twice weekly for a month, after doing PRP. Okay, so what's the PRP doing? Stimulating a local inflammatory reaction and collagen lay down to try to buttress and make that tendon stronger. And then what's the extracorporeal shockwave therapy do? Well, beyond what we don't know, what we think it does the same thing as the PRP injection. And they pushed her. I had gotten her back to a position of probably 50% of improvement in her adhesive capsulitis. And after we got through the intervention that they did, because they didn't do what I sent her over and suggested should be done. After they did that, she wound up with a worsening of her adhesive capsulitis. And now we're 8 weeks later in the same presentation. It's taken me 3 sessions to get her back to where she was before she ever went in for the intervention that they did. So it's just makes a person irritable. And then they said, well, if that doesn't work, yeah, we're not happy with the way things are going, maybe we'll have to do that capsular distension. No. Okie doke. All right. So maybe we can leave there with me sounding like I know what I'm doing and making me smart. That's a good spot for my ego to leave us with. Anybody have any input, thoughts? All right, you guys are awesome. This one's been recorded. I will post it up on the community board for you to review if you like. Please feel free to leave comments. Also in the community forum, guys, as you watch, Mark, I know you and some of the others have left reviews. Do that. That's helpful. Really, this is not about us promoting this process that we're doing as much as it is making it better. So I want your help in that. That's why you're lifetime members. And and that includes as well, shoot me some information about what you think this is worth. We're trying to find like any of us putting anything out there in the public, what a good product market fit is. I'm trying a monthly process right now because that makes it a little easier for some of the students that are out there wanting to do this. But my wife pointed out recently that if I'm selling continuing education courses here, most people buy continuing education and they want to know that they have it and not have to continue to pay for it. So she likes the lifetime membership, and I'm thinking that we'll just keep nudging the price of the lifetime membership up over time, and we will periodically do sales to get people buzzing and create a little bit more interest in people coming on board. But at some point we all have to actually demonstrate that this is a viable product and is serving a need out there in the world. So, okay, kids, I think that's good. I appreciate your involvement, and I will see you guys next week.